Hantaviruses are a lethal global threat. For decades, the standard path of infection has involved inhaling aerosolized particles from dried rodent droppings, usually while cleaning out enclosed spaces like sheds or rural cabins. However, the 2026 Andes strain cluster linked to a cruise ship confirmed that hantavirus can also spread through close person-to-person contact. Once a person is exposed, a biological clock starts ticking, but the patient has no idea. The virus utilizes an agonizingly long incubation period, lingering anywhere from 1 to 8 weeks before causing a single sign of illness. The true danger of hantavirus relies on this stealth. It replicates quietly, infiltrating the host system completely undetected for weeks before launching its attack. Entering the prodromal phase, a 5-day timeline shows generalized warning signs. Patients suffer high fever, fatigue, and severe muscle aches targeting the thighs, hips, back, and shoulders. Crucially, there is no runny nose, sore throat, or rash, cold symptoms absent here. Despite these distinctions, early diagnosis is difficult. During the first 72 hours, the viral load is often too low for standard serological tests to detect, frequently leading to initial assessments of influenza or COVID-19. This diagnostic trap burns through a patient's most valuable resource, time. While the patient assumes they are fighting off a common winter bug, a catastrophic biological reaction is quietly building in the background. Between days 4 and 10 of the illness, the symptoms take a violent pivot. The generalized muscle aches suddenly give way to a persistent dry cough and a terrifying inability to catch a breath. Here we encounter the biological paradox of the disease. The virus itself is not directly destroying the lung tissue. Recognizing the widespread viral invasion, the body's immune system panics. It triggers a cytokine storm, a massive, uncoordinated release of inflammatory chemical signals originally meant to fight off the infection. This microscopic cross-section shows the resulting damage. The massive influx of inflammatory signals causes capillary permeability. The tight junctions between the cells and the tiny blood vessels of the lungs break apart, allowing fluid to seep through the gaps. The patient's own hyperactive defense mechanism inadvertently floods the delicate lung tissue, initiating a lethal chain reaction. This rapid flooding creates a condition called non-cardiogenic pulmonary edema. The tiny air sacs in the lungs are actively drowning in blood plasma. Because this thick fluid blocks oxygen from reaching the bloodstream, the patient's ability to exchange gases plummets, resulting in severe, rapid shortness of breath. The lack of oxygen triggers a cascading failure onto the heart. The cardiovascular system strains to pump thick, oxygen-starved blood throughout the body, causing an incredibly dangerous drop in blood pressure. This total systemic collapse is known as cardiogenic shock. Without immediate aggressive intervention, death almost invariably follows within 24 to 48 hours of this phase beginning. Crossing into the Cardiopulmonary Phase moves the patient far beyond the reach of basic medical care. Surviving this stage requires total physiological rescue. The stark reality of modern medicine is that we do not have a targeted weapon for this pathogen. There is no globally licensed vaccine and no specific antiviral drug capable of curing Hantavirus Pulmonary Syndrome. Treatment relies entirely on intensive supportive care. Doctors are engaged in a race to physically sustain the patient's failing organs until the immune system finally resets itself. The first line of defense in the ICU requires delicate balancing. Medical teams must meticulously manage intravenous fluids to support blood pressure, while carefully avoiding overhydration that would worsen the flooding in the lungs. As the lungs fail, patients require mechanical ventilation. A tube is inserted directly into the airway to forcefully push oxygen past the fluid barriers and into the bloodstream. These early ICU interventions are purely defensive holding actions, fighting to slow the rapid collapse of the cardiovascular system. When the heart and lungs completely fail, doctors deploy their absolute last line of defense, extracorporeal membrane oxygenation, or ECMO. Looking at this ECMO schematic, we see it bypasses the patient's failing organs. It routes dark, oxygen-poor blood out, removes carbon dioxide, and pumps bright red oxygenated blood back in. Initiated early, the survival rate jumps to 80%. It is critical to explicitly mention any recent rodent exposure or time spent near known outbreak clusters to your doctor. Because this virus attacks with deceptive stealth and lethal speed, recognizing the early signs and securing advanced medical care is the sole difference between life